Examining the cervical spine for your area of greatest restriction is not difficult. So mostly we want to make sure we cover the entire cervical spine, starting at the base of the skull, going all the way down to the upper thoracics. I'm going to put my hand on the top of her head. I'm going to put my thumb and thenar eminence here on the side of the neck, and I'm going to gently side bend and rotate. And as I do that, I'm mostly holding this hand still and feeling, does her neck slide away from me? When somebody has a great restriction, those vertebrae won't move. And again, the key is to making sure you're going all the way down to C6, T1. Okay. And then of course, we're going to do this from the other side as well. And I'm sitting just for demonstrative purposes. Really, you typically do this standing. Again, directly on the side of the neck here, just lateral to the spinous processes, creating rotation and side bending with my top hand. A little bit of side bending with the thenar eminence and thumb. She doesn't have any significant restrictions, but had she had one, I would go back and screen and diagnose and treat that cervical vertebrae. So we've already gone over a lot of the motion testing in the cervical through the thoracic spine. So today we're going to get a little bit more detailed. Again, my hand here is going to be, my fingers are on the clavicle on the front. The palm of my hand approximately covers the AC joint, and then my thumb is on the scapula. This lets me have a good control over the shoulder, and I can induce that side bending and rotation. So again, I want you all to focus really. The thenar eminence is on the ipsilateral, or the same side of the spine that I am. So I find the spine, I work my way down, going nice and slowly and smoothly. You want to go with the same speed as the tissue moves so that you don't press too hard. If you press really hard and go too fast, it locks everything up. So slow is smooth, smooth is fast. Going all the way down the spine, and we do that on both sides. Again, hand on the shoulder and scapula, going nice and smooth. And when I find a tight spot here in the lumbar, we can slow down and I go one at a time and find her tight spot. We can say, right here when I induce rotation and side bendings, this is rock solid, so I will then diagnose and treat this vertebra. The indication for the ribs within the Stiles screen is finding a very tight or fully restricted immobile vertebra. And so as we come here on the vertebra, after we've done the whole screen, and I find this vertebra here in the middle, it's got to be a thoracic because that's what the ribs are attached to. I find T5 is highly restricted. I'm then going to check the rib that's attached to it. I find those ribs, and I'm going to bounce laterally on either rib, following the rib all the way out. If there's more restriction as I bounce out laterally, this is indicating that there is a rib dysfunction, and I need to lay the person down and do our standard rib screen and treat that rib that is the dysfunctional one. If it is getting looser as I bounce out on the rib, that is telling me that the thoracic spine itself is causing rib tightness, so I would treat the thoracic spine. One of the great strengths of the Stiles screen is finding bands. This part of the screen is quite excellent. And so what we're going to do is I'm going to feel right here, just medial to the scapula. We're looking currently for an upper extremity band, and this will be your indication that you need to screen and treat whatever you find in the upper extremity. So I need to start up nice and high on the shoulder. Again, I'm using always that thenar eminence, and I'm going to slide the paraspinal muscles here medially. And what I'm looking for is a spot that when I do blended palpation, you have to be blended, moving at the same speed as the tissue, it doesn't move. I'm not finding anything on this side, so I'm going to check the other side as well. Again, using that thenar eminence, stabilizing the shoulder, and sliding those paraspinal muscles. You want to start up nice and high so you don't miss anything. And as I come down, right here, just below the spine of the scapula, I try and blend in, and the tissue does not move. It's immovable, it's rock solid, so this would be my indication to look for an upper extremity dysfunction on this same side. So this is her left, so we're going to look for dysfunction on her left. And always compare right to left so you know what normal is. And I keep going all the way down to check. So this area here is the band for the upper extremity. Now, as we're talking about the lower extremity, you need to know when you're going to look for lower extremity dysfunctions. So in the Stiles screen, that's a lower extremity band, which is here. So again, I always use my thenar eminence, and I'm going to check for the band. I stabilize the shoulder, get a little slight side bending and rotation, and slide those paraspinal muscles. So I'm checking for a band here, all the way down to L5. A lot of people miss this lower part. They stop at about L4, this iliac crest. You need to really go all the way down so you don't miss something that might be aggravating the foot. And then we're going to switch the other side. Again, For the lower extremity band, we start down here. And as I'm sliding, I'm feeling for something that's movable. And on her, I actually start to have something that grabs here. I'm going to keep checking, go all the way down, and then I can always recheck and say, where was that really tight? And again, I'm looking for an immovable tissue. So as I come in, blended, nice and smooth and soft, moving at the speed of the tissue, when it stops really hard, that's when I know I need to treat. And I'm looking for a dysfunction on the lower extremity. And it is the ipsilateral lower extremity. So a right band would indicate a right lower extremity problem. As I was looking for lower extremity bands, again using my thenar eminence and my thumb here, if I look for the lower extremity bands and I come down all the way to L5 here and find a tightness here, and I find the same tightness on the other side, that's bilateral L5 tightness, and this would be the indication to look for pelvis and sacral dysfunctions and treat what you find in that area. Now that you've learned all the parts and pieces to the style screen, we're going to put it all together. So we're going to start with the cranial indication because I like to start top down always and go in a nice system so you don't miss or forget anything. So again, I'm going to start with the cranial, holding on the front of the head, pushing straight posterior to anterior at the base of the skull, looking for that leathery feel. I then just continue down, staying nice and high, and doing side bending and rotation with my front hand to look for those cervical restrictions. So we always do the entire screen. I'm going to come down, just doing the thoracic spine, again, doing that side bending and rotation with my hand on the shoulder here. And if I find a restriction, an area I think is really tight, I can slow down and then go one vertebra at a time to find a really restricted vertebra. I'm just going to note that in my head, and then I'm going to keep going. And remember that slow is smooth and smooth is fast. If you do this nice and gently and blend with the person's body, you will actually feel more dysfunction than if you go fast. So I did the entire spine on this side, and now I'm going to move to bands with the upper extremity band here. And again, this is now on the muscle layer. Looking for those bands, work all the way down. And you can note any restrictions, and you can have your patient tell you if anything is tender. Then I'm going to switch over to the other side, and again, I start just at the top of the skull, just force a habit there, and then work my way through the cervical spine, looking for any restrictions with side bending and rotation. Coming all the way down the spine. Make sure to go all the way down. And then doing bands. That's the upper extremity band, work my way into the lower extremity band. And then I've covered the entire style screen at that point. So anything that I noticed, such as a thoracic, if I had a thoracic vertebrae that was really tight as my area of greatest restriction, I could then go back and double check looking for ribs to bounce out to see whether it was rib or a thoracic problem or spinal problem. Also, if I had noticed bilateral L5 tightness, that would be my indication for looking at the pelvis and sacrum. Or, of course, upper extremity band being I would check this upper extremity on the ipsilateral side, on the same side as the band, and lower extremity band here. And now remember, this is the area of greatest restriction screen. So when you find things, most often as you get better, you won't find two things that are equally tight, and so you're going to treat the thing that's the tightest. So if while you were checking the vertebrae, you found one vertebra that it was rock solid, but you were also confused because there might be some tightness down here, you need to check to make sure that the tightness would actually be a band which is immovable. If it moves just a little bit, you need to make sure you treat the vertebra you found. Conversely, if you think this is just a little bit tight, but this stands out a lot more, you need to look for lower extremity and treat that. It's the area of greatest restriction. There's only one. So at this point, I have checked out my whole patient and I have done the full style screen. What I found is that she has a band on the upper extremity region here, which would indicate that she has a left upper extremity restriction. Now, I could just go directly to the upper extremity and treat. She was complaining of upper back pain, so I know that they can correlate, but it is good practice to do a whole physical head to toe, or the way I like to do it is feet up, and make sure you get into a rhythm. So what I want to do is find all the dysfunctions, and then I'm going to treat her upper extremity dysfunction, and then we will see what has resolved. So I first start at the feet, and this is just my way to screen. There's lots of ways to do it. We've taught you all the parts and pieces, so it's your job to start putting them together. But what I do is just a quick screen of the feet. I squeeze metatarsals, and I do a little fascial turn in and out here, and then I do talus check, and we can see that she's actually more plantar flexed on her right, indicating an anterior talus. She doesn't really have any significant restriction in her feet. And then I'm going to move up to the knees, and I check for tibial rotation, stabilizing that femur. Again, check tibial rotation. Both of those rotate pretty well. I also then check for fibular head dysfunctions, and please let me know if anything's tender while I'm doing this. Typically say that when I start, but forgot to do that, so I'm going to just do a quick hip check here and see, just check internal and external rotation of those hips, see if there's any drastic rotation there, as well as I can even grab the greater trochanters and slide medially to see if there's any major restrictions. And then I'm going to actually check the pelvis itself. So checking on that ASIS here, my right hand is higher, which is her left side. And then I can double check an ASIS compression test. It's actually her right side that is more stuck and it is lower. You can have somebody flip over once you've done this a long time, like I have. This is bad practice, but I do it. I check just reaching behind, and I know that the right PSIS is in fact higher, indicating she's got a right anterior pelvic rotation. And then I'm going to come up and I'm going to check ribs as well. Take a deep breath and out. And I'm going to check right here between your breasts. Is that okay? Mm-hmm. Take a deep breath and out. And I'm going to walk up, keep going. And she's got a little bit of a restriction here. They go further into exhalation than inhalation. So I'm going to double check rib 1 and 2 while I'm right here. Okay, so ribs 1 and 2 don't come up very well in inhalation, but drop further in exhalation on her left. So ribs 1 and 2 over here are exhaled. Are these tender also? Mm-hmm. Okay. So then I can check arm while I'm on this side, and I'm just doing a quick check because, like I said, her band was on her left side, so that's where I'm really going to spend a lot of time paying attention to dysfunction. And I just do a quick carpal check here. I'm going to check for radial head dysfunction. That moves well. And then I just check that side first because I knew that that's not really where I was looking for major dysfunction. And then I'm going to slide my hands up under her upper back, and I'm just going to start checking right at C7T1. She's got a little bit of a restriction. I can tell there, and I can diagnose too just by flexing her head. So she's rotated right, and it gets better in flexion. And then I can continue up the neck. When I was doing my original style screen, I noticed that she had quite a bit of restriction in her upper neck, so I can go ahead and diagnose that. C2 is the most restricted feeling. Okay. Well, rotate. So she prefers rightward rotation there. And then I can check the clavicles also. I just push directly towards her feet, and then I can grab clavicles and slide either way. Again, this is just the way I do a quick screen. There's a few diagnoses in there. She definitely had some hypertonic muscles in her upper back. She's got that C2 restriction. She's got a T7 or T1 restriction, and those ribs are also restricted. And then I'm going to come and, like I said, spend a little bit more time on this arm over here. Now that band can be anywhere. It doesn't have to be the full length of T1 to T9. It can be anywhere in there. And so we want to really just check out the whole extremity. So she's got a little bit of a radial head dysfunction. She is pretty restricted, doesn't like to supinate. So she is pronated, which means her radial head is posterior. And I can check that shoulder too and see if there's any preference for flexion or extension or abduction. Okay. And then I can work my way down to her wrist. And when I bend her carpals, that's tender right there? Mm-hmm. Okay, so under my thumb here, directly next to her thumb, there's scaphoid, there's thumb, scaphoid, so this would be trapezium there. And I can, it's pretty restricted. It doesn't like to move either in flexion or extension under my hand. So I can come back and I will see if anything is more restricted. So once you've gotten the area in which your area of greatest restriction should be, you need to focus down and go for specific dysfunctions that would be the most restricted. So throughout the rest of her hand, again, I was just moving the metacarpals. I like to rotate the fingers. None of that's too restricted, but right here doesn't move very well. So I'm going to treat that. I'm going to treat this with a functional type technique, or BLT almost. So I'm distracting, taking it to its position of ease, distracting, and allowing it to move. Again, you'll often notice that I treat with my eyes closed. It's actually a lot easier to feel things when your eyes are closed, and that's okay. I even tell patients that I'm going to do that. Okay. Now we're going to just recheck that diagnosis there. How's that for tenderness?
It's better.
Okay. So now when I flex and extend and move her carpals, that one actually moves quite a bit better. under my hand. So then we can recheck all of our diagnoses because we want to know what's changed. And this is also kind of a proof of that concept of biotensegrity. The whole body's connected. This will change things up through the whole arm as the arm was in a certain position to compensate for this dysfunction. So now that end feel is quite a bit better, as well as there's nice good spring, and she actually moves further into supination, so that's improved there. Didn't really have too much of a shoulder dysfunction. What we did have, though, we had some rib dysfunction, so I'll recheck those. Take a deep breath. Out. So both sides now move smoothly into inhalation and exhalation, so that's good. And then I can check right on her back again. There's still a little bit of restriction on T1, but it is very minor. Likely that will work its way out. And then I can come up. Oh, that C2 is much looser, so we can recheck that. Right. And easy left rotation. Okay. And sometimes that may even affect all the way to the lower body. Very often it does. So we're going to go ahead and recheck leg lengths. We're actually now even there, and didn't really have much restriction in the knees, so we can just recheck that pelvis and see. And the pelvis is actually much more level now. And check for that restriction. So this is a nice soft SI joint there, and we are level. So we've made some significant changes, and now it's your turn to go ahead and diagnose your partner. Again, remembering just that Stiles area of greatest restriction screen takes you to the area you need to really pay attention to, find a good diagnosis, treat it, see what has changed. Again, this is just my way of doing screening. A lot of the other preceptors will have very different ways, and it's time for you to start developing your own way to assess the body.